Research Conference. I am so delighted to introduce our speakers today. You'll be hearing from three of us from the DCRI, Dr. Ying Xian, who's Assistant Professor of Medicine and Neurology, Kirk Jernigan, who's with the Communications Group here at the DCRI, and me, who most of you know. But the main event today is really our two special guests, our Prosper patient co-investigators who've really been fantastic to work with over the past 3 years that this study has been going on. Deidre Hannah is a registered nurse from Texas, and Lesley Maisch is a patient co-investigator who some of you may recognize because she's a research conference veteran. She was here several years ago and had a fireside chat with Adrian Hernandez, who unfortunately couldn't be here today. But the wonderful thing about Lesley is she really doesn't hold back. So there was some really good-natured ribbing of the cardiologists in the audience during that session, and I know we all enjoyed that, so we hope that that will continue today. So the general theme for today's session is patient engagement, and this will be through the lens of Prosper, which is the study that Deidre and Lesley have worked with us on. But we'll also talk about, in addition to the overview and highlights of Prosper, some reasons for patient engagement. Why are we doing this? Why does it matter? How does it make our research better? And provide a couple of practical methods for engaging patients. Kirk will tell us about a phase 2 study in engagement of patients in an earlier research phase. So Prosper's focused on the outcomes side of things, but I think it's a nice opportunity to learn about how to engage patients earlier on. And then we'll invite up the entire group to have a discussion of the Prosper experience, the good, the bad, the ugly, and then we'll have a panel discussion about patient engagement, hearing from Deidre and Lesley, and hopefully also from those of you who have experience with patient engagement and have experiences and lessons learned to share. So without further ado, I will turn it over to Ying to give us an overview of Prosper.
Thank you. Can you hear me? Yeah. All right, thank you. I think this is a very tough job for me to describe what Prosper is. I have to say I was not born in this country. So before I come here, I know nothing about Star Trek. But I have to say that working on Prosper really got me a boarding pass to a spacecraft, which turned out to be a very prosperous journey for all of us. So what Prosper is? So Prosper is a patient-centered outcome research institute-funded study. The goal is to help patients, their caregivers, and also physicians to make informed decision-making about stroke care and improve stroke outcomes through patient-centered comparative effectiveness outcome research. So Prosper is very unique in terms that we are working side by side with the patient investigators. So the study is not only guided by healthcare professionals, but all guided by our patient investigators. So today we have the luxury to have two patient investigators here, Lesley and Deidre, and they will share with us their experience. So why are we doing Prosper? So I think the reason now is quite simple. If you think about the burden of stroke in this country, every year there are about 800,000 new or recurrent stroke in this country. If you think about how often it happens, every 40 seconds, someone is having a stroke. So after we finish up this 1 hour research conference, there are almost about 100 patients in the United States having a stroke, which is quite shocking. So the other thing is that stroke really is the 5th leading cause of mortality in this country, and also is the #1 cause of long-term disability in this country. Although many of us are working in the field of medicine, we know there are no lack of treatment guidelines to helping us, how to treat these patients. But in our conversation with our patient investigators, there are really two themes that comes out. So one is that we all know that from clinical trials, there are many therapies such as statin therapy and or anticoagulation. They can help us to prevent another stroke. But key thing is that how do they affect functional outcomes, their quality of life, and whether their time at home. So those are not the ones that seldom evaluate in clinical trials. The other thing is that we know that certain therapies are effective, but all those evidence is gained from clinical trials. They are highly selected patients. So does these results generalizable to less well-defined study population? For instance, patients like women, minorities, or they are older patients. So our patients really concerned about the long-term safety and effectiveness of these medications. How long do they need to be on this medication? Sometimes probably the rest of their life. And also they have some question regarding medications, how this medication they can impact their life. For instance, can antidepressant therapy improve their quality of life? Another example is a statin therapy as good for older patients as compared with the younger patients. And the other thing is that how oral anticoagulants could help me to prevent another stroke. So those are the common questions we learn from our patient investigators. We actually turn those research questions into comparative effectiveness research in 3 therapeutic areas, which is oral coagulation therapies, statin therapy, and antidepressant. So other areas also include the long-term benefit and harm of different medications, what their options are, what their potential harm and benefit for these patients. So what kind of outcomes are we talking about in PROSPER? So we know this is a patient-centered outcome research. We have traditional outcome measurement, such as MACE, mortality and readmission. But when we're talking about our patient investigators, the key thing really matter to them are not just survival, but is they really want to be stay at home with their grandchildren, with their families. That's the key. So we translate this concept of days alive out of the hospital, out of the skilled nursing home, and stay at home as a home time as the major outcome measure for PROSPER. And also we are interested in functional status, such as modified ranking, their mobility, and also something like we take it for granted. For instance, fatigue, depression, those are very common among stroke survivors, but they are seldom studied in clinical trials. So how are we going to answer these questions? We are using our existing collaboration with the Heart Association. We're using their Galveston Stroke Registry. I know many of you sitting here has been working on this registry. You know, this is probably the largest stroke registry in the world. We have almost 2,000 hospitals across the country, representing about 4 million stroke patients, which is about 80% of all stroke cases in this country. And also we augment this existing infrastructure with the CMS data so that we can evaluate long-term outcomes. And we also call patients, actually. We call them at 3 months and 6 months post-discharge. We want to learn their medication use, their functional status, and also their other health outcomes that seldom evaluate in clinical research. So what do we found? As we mentioned, that we are interested in how statin therapy could affect their quality of life and long-term outcomes. So we evaluate about 26,000 patients with ischemic stroke. We look at their discharge medication, some of them using statin therapy, others don't. As we can see here, that using statin therapy, they can reduce about 9% risk of MACE during 2-year follow-up. But what about home time? So on average, those taking statin therapy, they have an average home time of 544 days, as compared to only 470 days among patients who now using statin therapy. After risk adjustment, that is about 28 days. Think about that 28 days. It may seem very low or small numbers, but I want to ask, how many of you have been taking a vacation for 28 days during the past 2 years? I guess not many of you, right? If you told me that by taking statin therapy, I can have additional 28 quality days at home with my family, to me, I think that's a great deal. So in addition to these conclusions, we also find that very consistent results across different clinical relevant subgroups, including age, gender, minority, and whether their lipid level are, their stroke severity, very consistent results. And also we want to make sure that we're not only presenting this data in the literature, we also want to make these things available to our patients so that they can use them to make informed decision for their treatment. So we're working with our patient investigators, have this online tool so that can help with their decisions. So what about warfarin therapy? So we're looking at patients having atrial fibrillation before they have a stroke. all these patients are now taking oral anticoagulants before they having a stroke. So what we found is that among those taking warfarin, they can reduce about 13% of risk of experiencing a MACE event during 2 years of follow-up. And it's most surprisingly that these patients can get additional 48 days at home during 2 years follow-up. To me, I think that's a really, really big gain for these patients. But when we're looking at those data, I was wondering, it seems like a lot of patients are now taking warfarin therapy, even though they do know they have atrial fibrillation before they have a stroke. If this is very common in practice, perhaps it's suggesting that we are not treating patients appropriately. So that's why we make a little bit further and using more recent data and see among patients with atrial fibrillations, we really want to know what kind of medication they have been taking before they're having a stroke. So what we found is that among 95,000 patients, almost 1/3 of them are not taking any oral antithrombolytic therapy at all. And then about 30% of these patients, they are only taking baby aspirin or particular. And then there are few patients taking warfarin, but the majority of them are not in their therapeutic range, which is really alarming. If we add all those numbers together, that means 83% of patients, they're not taking medication according to treatment guidelines. The other thing I want to mention is that even in the rare cases, patients still taking warfarin, therapeutic warfarin or NOACs, but unfortunately they have a stroke attack. But it turns out that these patients will have a less severe stroke and less likely to die. So this finding really highlights the huge opportunities to improve care and outcome for patients with ischemic stroke. I need to say that this idea really is coming from Eric and Adrian, but actually we are inspired by Lesley. Many of you have known this 3 years ago when Lesley visited us, she shared with us her story. She has a valve replacement, taking warfarin, but she's a workaholic, and she doesn't have time to check her blood, but unfortunately she has a stroke. So actually, I think by doing this kind of research, we really learn from our patient investigators and really helping us, to disseminate this information to the medical society and also the broad lay audience so that we can help them to improve their care and improve their outcomes. So with that, I'll hand it to Emily and talking about patient engagement.
See, test. Okay, great. So thanks so much, Ying, and I think that just gives you a little bit of a flavor for how our work with patients supported development of a plan, a platform for research that ultimately led to some really important findings that we hope will be used widely in clinical practice. But for this part of the talk, I'd like to take a step back and talk for a moment about why we even do this work. Why does patient engagement matter? And one component of that that I'll talk about later is how do we actually do this if we agree that this is something important and that should be a component of research projects that we do. So I have a couple of audience warm-up questions as we get started here. Show of hands, how many people have used patient data in research projects? Okay, so good number of you. Some of you who I know have and didn't raise your hand, but that's okay. Question two, how many of you have interacted with patients in research projects where they fill roles other than research subjects? Okay, so still a few, but I think it highlights that we have some work to do, that patients really contribute a lot when they take part in a trial or a study, and involving them in the planning phases and generating ideas and helping with the conduct of the study is really an important step that we need to be taking as researchers. So I wanted to tell a story about patient engagement. In full disclosure, I got married in December, and when you get married, people offer you all sorts of advice. One of the common themes of the advice that I got when I got married is that all relationships go through phases, and I should be first of all, aware of that, but second, that I should really try to remember how I felt on my wedding day when inevitably more difficult or challenging growth phases of marriage approached. And so I think the same sort of progress and path can be applied to our story of patient engagement. So I have this set up as a love story. So the first phase of this story is when we were contentedly alone as researchers. This is most research prior to 2010. As researchers, we were happily living the bachelor life, conducting research with little input from patients. And then PCORI was founded in 2010, and there's a funding stream that was focused on engaging patients. And all of a sudden, there's a lot of interest in doing this work. And people were sort of looking around, and everyone else seemed to be pairing up. Some of you probably went home to Thanksgiving dinner, and you had an aunt who asked you why you hadn't found a nice patient to settle down with yet. And so that led to this period of discontentment where we recognized that this was something that needed to change. And then the partnership started, and we entered this honeymoon phase where nothing could stop us together. We were doing great work. Partnering with patients was even better than we ever dreamed of. And as with all relationships, there's a phase after the honeymoon where potentially some hiccups in communication, maybe comparisons with the past when it was easier just to do research on our own, and this necessary realignment of expectations on both the side of the investigators and also the patient partners. And the point I'd like to make is that what we're really working towards is this phase where we're contentedly together, and where everyone on the research team is recognized as an equal partner that contributes equal value, and that we're accepting of each other's flaws and there's patience and a focus on continual growth. So easier said than done, but I think it helps to know sort of where we've been and where we're going. I would also like to just note that PCORI started in 2010 and it's now 2017, so I'm sure there's something to be said about a 7-year itch, but hopefully we'll move beyond that. Okay, so those of you who are familiar with PCORI know they've done a lot of work to really crystallize this process for engaging patients, but I think it's important to recognize that patient-centered care isn't a new concept. This is something that's been around for several decades and was actually highlighted in the landmark Institute of Medicine report in 2001, Crossing the Quality Chasm, and the whole idea here was really that we have a large gap between the care that we have today and the care that we could have. And helpfully, the Institute identified 6 domains of quality that we really need to focus on in order to narrow this gap and improve all aspects of care quality. And they weren't given in any particular order, but if you're a patient-centered outcomes researcher, I think your argument is really that the focus on patient-centered care drives each of the other 5 domains of quality, right? So if you're a clinical trialist and you focus a lot on safety and effectiveness, that's only one part of the continuum of care quality. Quality that's patient-centered is also equitable, timely, and efficient as well. So as I mentioned, PCORI's done a lot of work in sort of crystallizing the concepts around patient-centered outcomes research. And when this was first starting, there were a lot of questions about what this meant. What do we mean by patient-centered outcomes? And what is PCOR? And I thought this was a really useful way to think about it. These are 4 questions published by PCORI that patient-centered outcomes research is designed to answer. So questions like, given my personal characteristics and preferences, what should I expect will happen to me? What are the treatment options and what are the benefits and harms of each of those options? How can I be involved in my own care to improve outcomes that are most important to me? And how can I work together with clinicians in the healthcare delivery system to make the best decisions about my health and healthcare? And a lot of this work was driven by this recognition of what most of us know now, which is that the priorities of physicians and caregivers and surrogates, nurses, don't always align with the preferences of patients. And the support study, I think, was a really striking example of that, where they asked about preferences regarding end-of-life care and found that the agreement between those preferences among those parties was only slightly better than chance. So I think it highlighted a real opportunity for communication. And what patient-centered outcomes research aims to do is really to support and promote care that's in this center of the Venn diagram here, that not only reflects the clinical evidence and expertise of the care team, but also the biological, sociological, and psychological context and the patient and caregiver preferences for a really comprehensive treatment decision. Okay, so this is a systematic review that was published in 2014, and there's a lot of curiosity about of all the different methods for patient engagement, what's being done, how can we summarize best practices. And so they looked at 142 studies that described the spectrum of patient engagement and found that most of those studies reported that engagement was feasible, so that's good news. they looked at various phases where that engagement occurred, and primarily during the agenda setting and protocol development, which is good news that it wasn't that the study had been conducted, then patients were asked to help with just dissemination, that they were helping to drive some of the development of the research aims. But also that there's to date not really a lot of systematic comparative analyses of best methods for doing this. So there's a sort of assumption that engagement is a good thing on some level, but comparisons of strategies for how to do this best and make sure that it optimizes that interaction and that it's of benefit to the patient partners, we have a lot of work to do in that area. Another piece of this that I really liked is the systematic review outlined specific benefits and challenges of patient engagement. So I think often when we think about the benefits, there's the sense that it's this sort of moral imperative to involve patients. It's the right thing to do because they're the ultimate users of the research. And that's true to some extent, but I think there are also really key practical benefits that we need to acknowledge as researchers, and that can help to motivate some of the adoption of this of this work, increased study enrollment rates, helping researchers in securing funding, helping with protocol design, a huge component of a successful research protocol, obviously, is an intervention that patients will be compliant with and will not hate, and that can help reduce dropout rates. So that's a critical piece. And then choice of relevant outcomes, which will enhance uptake of the evidence in clinical practice. Of course, a couple of challenges that need to be noted, logistics and extra time needed, of course, to involve additional stakeholders, potentially extra funding, and then this worry of tokenistic engagement. I would argue that these are true for involvement of any additional stakeholder beyond the immediate research team, so those are nothing new, but I think we can agree that the benefits of enrolling patients and having their input both early on in the study and throughout is that it far outweighs some of the challenges associated. So this is from a systematic review done by a team at Mayo, and I think it's a little bit hard to see, but my purpose in showing this is really to emphasize that there's nothing magical about developing relationships with patients, that the ingredients are the same as ingredients of any other successful relationship: trust, transparency, openness, reciprocity, again, making sure that there's added benefit of participation from patient co-investigator standpoint, and of course also honesty. Also key in this manuscript that I really liked was this emphasis on longitudinal relationship building and sort of periodic check-ins to make sure that the needs of every research team member, that those are being met along the way. So I think this slide is from IAP 2, and I think it summarizes a lot of the sort of from a global standpoint, some of the approaches and really the message here is that there's a spectrum of patient engagement. And what I like about this is that it incorporates the patient's goal as you're thinking about developing a research protocol and involving patients, that the patients have various goals for being involved as part of the research team, and that those really need to be reflected in the ultimate strategy that you choose. So this can range all the way from over here on the left side, a more passive sort of engagement strategy where the patient is learning and where the research team commits to informing the patient if the goal of the patient is to suggest ideas and opinions informally and really just to learn. Our promise as researchers is that we will respect and hear the opinions and thoughts of the patients and also keep them informed. And as you can see, this goes all the way along the spectrum towards more more active ways of involvement, of consultation with formally providing opinions, all the way to collaborating where patients are partners on equal footing with researchers, and then to empowerment and leadership of research projects where patients are the ones who are making decisions and leading research activities. And as investigators or co-investigators, our commitment is to follow their lead and to support their decisions. This looks pretty structured, but I think the point here is that there's a lot of flexibility in approaches, and certainly some of these may be more appropriate strategies for one study versus another. So again, I think the key message here is to engage early and to engage often and to make sure that the patient's goals are reflected in the engagement strategy. Another challenge that's brought up a lot is this concept of tokenistic engagement or engagement with one patient partner who happens to fill that role in multiple research studies, and does that really give us the diversity of opinion and perspective that we need? I really liked this review by Kaufman that highlights some creative ways to partner with patients beyond just recruiting them directly from a clinical setting. So of course patients are people, and they're part of groups outside of healthcare delivery systems, and that can be a really great environment and mechanism for identifying people with whom we can successfully partner in research. So I did want to mention, I think the Prosper team is all familiar with all of this, and all of you are as well if you've ever worked with patients. There are some administrative hurdles that I think need to be acknowledged by anyone who wants to do this work. And in Prosper, we had some issues with contracts. You can see this guy, he actually, this is a real shot, he just got finished with some conflict of interest training, and that was his expression. So there's a lot of legal mumbo jumbo in the forms that our co-investigators are required to fill out. We had to get a waiver of the insurance requirement for subcontracting, and had to kind of start from the beginning for any of our co-investigators who moved. This also was really obvious to me in the manuscript co-authorship part of this. So this is really important that our patients were involved as writers and editors of our publications, and they have been for 6 of those that have come out of the project. But just things like identifying what the institutional affiliation is for patients. Disclosures and copyright transfers, the verbiage is really cryptic and it can vary across journals, and there's this need to create an account, and just barriers, I think, that can present a burden to patients as they're involved. And I think as researchers, we can be advocates for a more streamlined process that will help encourage participation and not be such a headache that we partner with patients and then they are traumatized and never want to do it again. Okay, and so wanted to end with just a highlight or mention of some of the great work that's going on at Duke to develop tools and to support us as faculty and staff in how to do this work. This is a slide from the City Group, and I think nicely highlights how patients can be engaged in research from the pre-discovery phase all the way through to outcomes, and would encourage you to go to the City website and check that out if you're interested in some additional information. So in conclusion, we've made significant progress. Challenges remain. I think we have a real opportunity to demonstrate how to do this well at Duke, and also to disseminate our findings to other research teams. Of course, the process should be iterative in learning, and learning from one another through cross-disciplinary collaborations is really key. Okay, so I will turn it over to Kirk.
Hello? Oh, hey, I found it. All right. So the project we'll talk about involves a sponsor's study portfolio for obstructive HCM. And the communications team involvement really began last year under a more traditional scope of activities, study naming and branding, and working in collaboration with Dr. Matt Rowe and Dr. Andrew Wing. And that really opened the door for us for a Phase 2B opportunity. It's scheduled for May, begin in May. And the sponsor wants to start an expert steering committee that will include a patient representative whose views will carry equal weight with other members of the steering committee. And so our scope involved with this particular project involves the patient engagement and education of this member. And that work, which is really just beginning, we're in the planning stages, but we have kind of got some things underway, involves developing a summary of the patient representative profile, documenting and helping to establish the selection process and support the selection committee, as well as help select, train, and support the chosen patient representative. And kind of one general comment I'll touch on again in a second is we don't have definitive guidance from the FDA or other regulatory authorities implementing this, but we do have, where they've publicly recognized the importance, and they may favorably, more favorably view studies that have this aspect in their projects. And so, like I said, it is a work in progress. We're planning, developing, and documenting this guidance and this selection and identifying a patient representative because we really want to establish an approach suited for the therapeutic area, the patient population, the study, and the client. And that really involves a partnership and a deep engagement with the study PIs and getting their guidance to enable this process. And as we move along and as we go through selecting and identifying the patient representative, we're documenting lessons learned to shape and define our future approach. And with the goal to ultimately develop a DCRI best practice recommendation to guide similar initiatives for other sponsors in therapeutic areas, because once again, we don't have this definitive guidance, so it's crucial we set up a robust internal process for how we're doing this. And so as we work on this, we looked at what should be the patient representative's role. And a few key things here will be to work with other steering committee members to review relevant literature in the disease area, as well as study protocols in relation to patient-reported outcome endpoints, anticipated participant experience, and the study burden. And also, we expect the patient representative to be able to provide feedback on study conduct, particularly how it relates to the participant experience, informed consent form, recruitment and retention tactics, educational materials, site materials, and the plan for public dissemination of study findings once those are available. And some of the benefits we consider of having the patient involved in these areas, looking at protocol design, making sure those PRO endpoints are included, so we can assess the clinical parameters that might matter to this patient population, things like fatigue, energy levels, quality of sleep, ability to perform certain tasks, and also so they can advise on the study burden for trial participants, how to optimize patient comfort and convenience within the protocol constraints. And other key areas to participant recruitment and retention, helping to inform on our tactics to maximize enrollment and minimize dropout, improve the effectiveness of our study materials, and advise on participant support and motivation. And so we've been working internally and with the sponsor on developing our proposed selection and engagement process. And some of the key areas we've developed so far, confirming the sponsor's objectives for this initiative, developing the profile, like I said, in collaboration with the lead PI, or PIs in this case, and going through a process of approving the profile and role. We're going to be developing a nomination form, and each member of the steering committee gets one nomination, and then we'll have a short list, and then assess the shortlisted individual's interest in serving on the committee. And then, of course, the sponsor gets to make the final decision about who will serve. And then once we have that, we'll start the support, training, and empowering process. And some of that will be, customized to this person's, preferred learning style, that particular knowledge set. And it has a couple of different options we're looking at there as well. So I wanted to share with you the draft profile of the patient representative. We're still, refining some of this, but at this point, we have 5 different categories, mandatory, preferable criteria, and kind of going through these. The clinical and treatment status. We want someone who is really kind of close to the patient population and can represent that patient view well, but would be excluded from this particular study. And also, it would be the first study with the, they wouldn't have any previous experience with the sponsor in serving in their studies. And also clinical research experience, no conflicts with other competing studies, but have some background in clinical research, maybe participated in a study before. And as far as educational background, a high level of health literacy, someone who feels confident participating in a committee with physicians and members of the scientific community and can contribute to those discussions. And a couple other, more patient advocacy, being able to represent these wider views, in touch with the patient, community, and then some more practical considerations of, being able to attend meetings, location, and no other conflicts of interest, such as personal connections or financial connections. And so that's it. It's it's an evolving project. There's going to be some different changes and a lot of stuff, lessons learned as we move forward. Feel free to contact me if you have any questions, want additional information. I'm always open and look forward to hearing from anybody.
So at this I'm going to ask our speakers to come up and join the formal panel that we've arranged here. Yeah. So I think mine is still on, but if Kirk, would you be willing to pass around for? Okay. So I'd like to, with the time that we have left, first start with we have a brief introduction of Deidre and Lesley, but if you don't mind, if you're willing to tell the audience a little bit about yourselves and how you got involved with Prosper.
Hello. Yep.
So my name's Deidre Hannah, and I got involved with Prosper via I was working on my master's degree at UT Southwestern in Dallas, and Dr. Hernandez contacted, I guess, during the grapevine, the social worker on the rehab floor where I was doing clinical rotations for my degree, and asked if she knew of anybody that might like to be involved with the study. And she approached me about the information, and I called Dr. Hernandez, and we had some discussions, and then I ultimately decided to be involved.
Adrian's very persuasive.
I'm Lesley, and I got involved because I was a volunteer with the American Stroke Association local chapter in Buffalo, and the person that I reported to as a volunteer had received an email from Dr. Hernandez asking her if she knew of anyone who was a stroke survivor and would be interested, and the rest is history.
So maybe I'll start off with a question before we open it up. We talked about the experience with Prosper and the good, the bad, the ugly. Would you say your experience has been mostly good, mostly bad, and if it's ugly, just don't tell us? What's it been like?
For me personally, it's been good. I don't know really that there's any bad parts. It's been good that they have been receptive and really interested in my opinions and thoughts as a whole. The only difficult part, I guess, would be the monthly or bi-monthly conference calls that we have with the other investigators and physicians involved in the study. And for me, it's really technical as far as research goes. I'm not experienced in research, even though I am an RN. That's not my forte. But we had a call with Emily at one point, and it was just Emily and the investigators on the phone. And I felt like we were able to discuss more our comfort and get across kind of what we wanted or kind of our ideas. And I personally felt more comfortable expressing my thoughts and ideas in that setting.
What she said. It's been a really good experience. Better than anything I ever expected. This is so emotional. The best part has been the fact that they listen to us. And the conference calls are usually way over my head because I am not even medical. I'm just a patient. And the smaller calls, like when we did the coordinators, and when we had the call with Emily, Emily called our call quite heated. And, and it was because we were really passionate, you know, and yet you listened, and you guys incorporated, you know, what we said. And it means a lot.
Well, can you still hear me? So just a couple points, maybe 3 points. It obviously means a lot to us too. We try not to get emotional, but it's been an incredible experience for all of us, the whole Prosper team. Second, the conference calls are just as painful for us as they are for you, and too technical by far. So I'll take that feedback to the group. And then the third piece is that when I think back to that call that was heated, and I think it was, and that's the type of interaction that we're really looking for. Interesting story. So these two will say they know nothing about research, but we were going over the results, I think, from our statin manuscript, and Deidre said, so you're using the medication information from discharge. How do you know if the patients are actually taking it after they leave the hospital? Like, don't you have data on adherence? And I said, next question. But I guess that's to say that you are both very savvy, and I think that is those types of interactions really do highlight some of the potential limitations of our the work that we do, and what should be appropriately reflected in discussion sections and when we present the work. So it's not just that we appreciate the involvement in the goal setting, but also the interpretation of study results and really trying to frame our findings in a way that acknowledges those limitations. And I thought it was just a really astute comment, and one that we ultimately ended up incorporating in the paper. So thank you. And I think we have a special guest who's going to be calling in.
Hopefully.
Okay.
He knows it's Tina.
It should be on his schedule. Should we leave him an angry message? Okay. Well, we'll wait for him to call back. But maybe we'll open it up to some questions from the audience at this point. Yes.
Hi. Thanks for all being here. I found it incredibly helpful. I'd like your opinion on, when I heard about some of the training for steering committee, I felt worried in the sense of if you're looking for people who are health literate, have a certain education, I worry that you narrow down. I see the patient being a patient makes them the expert, and there's language about training the patient on how to be on a steering committee. And I worry that then trains them out of being who they are with their own experience. So some of what I see is needing training to the medical team of how to work with patients on, part of the engagement panel. And so I don't know if I'm getting this across clearly, but I wouldn't want you to limit people who are on a steering committee because of their education level. Or their health literacy, because those are the people who are going to help you understand how hard it is to be a patient being enrolled in a study or being approached in a hospital or learning about treatments.
I could not agree more. Some reactions from our patient co-investigators. I'll say that we didn't do any formal training at the beginning. We talked about maybe one suggestion was, I think that maybe you're referring to, is this concept of like a mini MPH, where there's this sort of crash course in general research terms and what they mean. Is that something that would have been helpful, or do you feel that not having any formal training like that was actually maybe a good thing because it helped preserve your perspective as a patient, as a non-researcher?
Yeah. Well, I just want to say I'm I was a secretary. I have no health training at all. It was just my experience of surviving a stroke and the recovery that I lent to the research study. And as far as training is concerned, when I think of training, I think of things to expect, like the contract legalese. And Barb, where are you? Oh, yeah, okay. If it hadn't been for Barb Lytle, I never would have been able to complete the forms that were required. I was emailing her all the time and saying, what am I supposed to do with this? So that's the kind of thing I think of as far as training is concerned, or at least having a go-to person to help me with that, So that was, that when I thought of training, that's what I thought of. But yeah, I wouldn't be on this steering committee and part of this research project if they had been looking for someone with a health background. So I just want to say that. Anybody else? Did you want to?
No, I think it's a very valid point. I appreciate you bringing it up. And I think, we are looking at training and still defining it. And, the college background was a request from the sponsor. However, we are pushing for a customized, train. I think some of it, like you mentioned, training on the actual study, what the mission is, the goals, and then just familiarizing if this person's never been on a steering committee, kind of what that entails. But I think it's a really great point as well for you that you made about being others on the steering committee being trained as in patient engagement. So I do think it'll be both ways. So I appreciate that.
We do have some stat training. I guess you guys have been taking on, but I guess in terms of training, it has to be both ways. Not only we train the patients, but also patient investigator actually training us and helping us to identify the right research question using the right way to answer those questions. I can give you one example. So when we first start the PROSPER study, we have a therapeutic aim of use of TPA for patients with acute ischemic stroke. But when we're talking with the patient investigator, actually those are not the things that really matter to them because it's the treatment decision made by a physician at the emergency room. But what really matters to them is what their long-term outcomes after discharge, what kind of medication can help them to improve their quality of life and have better functional outcomes. Those are the key things that we learn from our patient investigators. The other example is use of home time, which is the patient-centered outcome measure for PCORI study. That's the key. Actually, we learned this from all our patient investigators.
My only thought is if you don't have any educational background, that the talks by the researchers and physicians would go over the heads of a lot of people. And then I'm not sure you would understand even a basic understanding of what the researchers are wanting or looking at. So I think it really depends on what you as researchers are wanting from your patient investigators.
Okay, so we've been joined by our VIP mystery guest. Some of you may recognize him. He's at a far less important meeting, but we couldn't let him off the hook. We knew that there were some hard questions that needed to be asked. So I think he's actually going to kick us off with maybe one question, and then we can turn it over to you all.
Yes. So
We'll do it.
Emily, I don't know if you can hear me, but sorry I couldn't be there. I'm just getting out of the pool here in Miami.
I'm hanging up now.
Let me start off with one question for Lesley and Deidre. Do you all have a different view or perspective on cardiologists now in the last 3 years? So if you could comment on that.
So, she's shaking her head. No.
I'm gonna let Leslie.
Yeah, that's for me because apparently I bashed all cardiologists when I was here in 2014, but no, really. No, I love my cardiologist. It was only the resident cardiologist who was in the hospital, I'm sorry, when I was recovering from my stroke. So, yeah.
So I guess more seriously, the kind of question here for the group, and maybe you've already addressed it, but 5 years from now, what do you think that we at DCRI should be doing regarding engagement of patients as part of research? What should it look like?
Who would like to take
That
this
can
one?
be for anyone on the
Or,
panel.
okay. Well, sorry, this is kind of awkward. I'll just, okay. So I think the big thing is really sort of the common theme that's been noted, which is that we need, I think, more diversity, and we need to make sure that it's not just the perspective of one or two patients, but that we're really leveraging the connections that we have to broader groups and making sure that those ideas are incorporated. I think the temptation is to find some people who you really love to work with and to continue to keep those relationships going. But I think we need to challenge ourselves and get outside of our comfort zones and connect with patients who may not be as accessible to make sure that a really diverse set of perspectives are incorporated. Other thoughts?
I guess for Lesley and Deidre, should we be doing this in every study, or how would you rate your experience here, 0 to 10?
0, oh, you had to put a number. You had to put a number on it.
To measure everything.
No, it was a really fantastic experience, and I am very excited that patients are being involved the way you guys have done it with your research. I would love to see more research if you're going to focus on stroke again. But in the younger population, I know that the only numbers that you had to work with were Medicare numbers, but so many strokes are happening to much younger people, and I think some focus needs to be placed on that. And when young women, and I've heard this story from too many women in their 30s, when they present to the ER with stroke symptoms, are sent home told that they're having a panic attack, and I just think that's so wrong. So studies, I don't know how that can be incorporated into a study, but I just feel like if you're going to do more work on stroke, the younger population needs to be focused on. Did I answer your question?
Okay. Any tough questions for Dr. Hernandez before we sign off? Okay. Thank you, Adrian.
Thanks a lot.
All right. Have fun in the pool. Okay. Maybe one more question from the audience.
So it sounds like you've been part of the study for 3 years, which is a pretty substantial amount of time. And I'm just wondering if you could talk about the time-benefit trade-off for you, whether 3 years was a perfect amount of time, or whether it was too much and too intensive for some patients to be part of.
Are you sick of us yet? Is what?
No, I think the amount of time has been good. In the beginning, we weren't sure about them, and they weren't sure about us. So I'm sure we didn't do a lot of communication. But in the end, 2 and 3 years, we've gotten more comfortable with one another, and really the information exchange between us has been greater as far as I'm concerned. We have monthly or bi-monthly, quarterly conference calls and yearly face-to-face meetings. And the time for me has not been too much or too little, but I feel like my impact has been good as far as they listen to what I have to say and try to incorporate my thoughts and feelings into the study, and I have seen that over the 3 years, so it's been good as far as I'm concerned.
Yeah, I agree. I don't think 3 years was too long, and I actually looked forward to the responsibility, if you want to call it that, of being involved with it. And, you know, I've loved working with the team and getting to know them better. Yeah, so I think 3 years was good. I'd love to go longer. We're hoping
Done.
to prosper too.
Thank you, everyone. Oh, Ying.
Can I say something? So actually, it's now 3 years. Has been 4 years since you first started, and the other thing is, yes. So the other thing is that Emily actually leading these efforts for Prosper too. We are really looking forward to have another few years of working with our patient investigators.
Just got to get it funded. Well, thanks for your attention.